So just to kind of introduce the topic here today, this workshop is called Building Bridges Between Harm Reduction and Treatment for People with Substance Use Disorders. So there's sort of a lot even in that title just to think about, what do we mean by harm reduction? What do we mean by treatment? Who are the groups of people that we're targeting with, any type of intervention. So, these are all topics kind of we'll be discussing. This is a two-part workshop. So the first half will be today, and then the next half at the same time next Monday. So hopefully everybody can join next Monday as well. So just to kind of go over this disclaimer, this workshop and training was supported with a grant from SAMHSA, but the contents are solely the responsibility of the Northeast and Caribbean Addiction Technology Transfer Center and don't necessarily represent the official views of SAMHSA. And I will just add that this is sort of the third version of this work, or third time this workshop's been offered. So kind of keep learning about who signs up and, trying to tailor it to participants. So again, if you're just joining, feel free, or I'd encourage you to add your name in the chat and, broadly your role and where you're joining from here today. So just to, I'm sure many of you have heard, kind of discussions about language and, trying to use people first language, just to be mindful today, people are still learning, word shift and, just try to be sensitive and also respectful of, where people are at. I try to use addiction as well as substance use disorder, talk about treatment pretty broadly, and then also kind of recovery very broadly. And, we'll be talking about some of the meanings of different terms. So, encourage everyone to use the chat to kind of have a discussion and, comment on things or ask questions, or raise your hand. Please try to share the floor and be respectful of kind of, who's speaking and giving everybody a chance to share and ask questions. So just a little bit about me, I have a background mostly in journalism and taught media ethics in New York City. And in 2017, returned to school for a master's in public health degree. Mostly since then, I've been working on projects to reduce overdose deaths, educate people about harm reduction, improve access to treatment, and support people in recovery. I come out of that writing and media and journalism background, so really try to see sort of 360 perspectives on things, and that's part of what informs sort of the approach to this workshop. Often I do collaborations with my husband, Graham McIndoe. I've mentioned to some of you who heard he's Scottish, he's a photographer. And he's been open about his history of addiction, incarceration, and recovery. So kind of now almost 13 years in recovery. So a lot of the projects we've done, try to work a lot with groups of people who have personal experience with these topics and have really kind of tried to develop what we talk about as sort of a collaborative storytelling approach. So on the left is an exhibition that we co-curated, with a number of, people, mostly photography and students. So, we've curated this exhibition that's traveled, both in New York City and up to Rochester, really trying to, the title was Beyond Addiction, Reframing Recovery, and trying to get people to think about sort of the whole kind of continuum of services and, worked and taught classes with students who also contributed artwork. And then on the right was a public art exhibition from another project where we were able to visit a number of mostly harm reduction and treatment providers in 4 different states and interview and photograph people who were both providing services and receiving services. So that was exhibited on a pier in Brooklyn Bridge Park in New York City. Any questions, feel free to post in the chat, but trying to use this, might recognize that bridge in the forefront in Brooklyn, but the bridge is a metaphor. I think anybody who's been following this or working in this field for a while kind of understands that things can be pretty siloed and that, funding streams, conferences, research, tends to specialize in one area or another. So I like to say that, I like to work in the spaces that are kind of the connective tissue between different groups. So that was sort of the genesis for this workshop. to think about, okay, how can we, facilitate sort of bridges between harm reduction as an approach and treatment for people with substance use disorders. So these are some of the learning objectives. These first two we'll kind of focus on today, and then the second two next Monday, but really thinking about increasing knowledge about harm reduction principles, practices, and impact. And then address questions and concerns about harm reduction and treatment for substance use disorders. So, we'll be talking about sort of ways of looking at those things and different definitions. And then next week, discussing ways to strengthen those connections between harm reduction, treatment, and other support services. And then explore how treatment providers are kind of increasingly taking a bit more of a harm reduction approach into their work. So this is, I don't know if a poll is going to pop up, but feel free to, or please answer in the chat if you just want to put a number 1, 2, or 3. How familiar are you with the concept of harm reduction as an approach to substance use? So the first option is very familiar. I could explain what it means. Somewhat familiar is number 2. I've heard of it, but not quite sure you could explain or give a definition. And then 3, not too familiar. So we see we have kind of a split of 1s and 2s, a 3 in there. 1, I think that's okay. You could be a 1.5. You might be a 2.5. So great. A lot of people. There's a question there. I'm not sure that I can see specifically a mic, but if you hover over yourself and hit mute, that should mute you if necessary. But I'm not hearing anybody's noise, so for that question. Okay, so a lot of 1s and certainly many 2s there too. So, my next question is, thinking about, if you were out maybe in a social situation or talking to someone who had never heard of this phrase. Sometimes I'm surprised by when I talk about it with friends, a lot of them haven't heard about it, the phrase harm reduction, who I would have thought had. So, just invite anybody who feels kind of comfortable answering this. How would you describe harm reduction to someone who asks what it means? So maybe start by, we'll take a couple minutes to type something in the chat for those of you who feel comfortable offering up a definition, and then we'll talk about some of the responses. So Laura writes, engaging in substance use with the least amount of harm possible. Karen, I think yours might have gotten cut off. Genevieve writes, meeting them at where they're at in their recovery. Velia, reducing harm, risk, and teaching safer use. Diana, providing services to keep people alive. Great, Karen's adding. So a lot about safe use, safer ways to use. Joseph, measures that reduce risk of relapse, overdose, and deaths. Naloxone training and distribution. More reducing harm. So feel free to keep adding to the chat or kind of commenting. Gary writes, in terms of substance use disorder, reducing the consequence of drug use, death, wound care, and legal repercussions, right? So interesting kind of thinking about pointing out in the context of substance use disorder as opposed to just substance use. So there might be different interventions depending on how someone is kind of presenting in their needs. Helping to ensure better quality of life. And again, bringing up, thank you, Donald, that abstinence may not be the overall destination for some folks. And Vanessa, ensuring community safety, right? So thinking about individuals, families, and communities. So I'm going to show a few definitions here just to kind of illustrate how, different groups can kind of approach this. So this comes from the Harm Reduction Coalition, and they have a lot of information on their website. And again, you will get all the slides, so I try to include all the links here. And they define it as harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Then the second part says harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. So, looking, kind of unpacking this a little bit, there's a couple things you might notice, and on their website, when they, kind of provide more context for these definitions, they talk about the lowercase harm reduction in the first phrase there, so that's really focused on this idea of practical strategies. And then the capitalized harm reduction is thinking about it as a movement for social justice. So I think we've seen more of that, in recent years, as harm reduction becomes more accepted and gets more support, that there is this sense of kind of connecting that to a wider movement and other organizing around social justice and kind of the needs of people who kind of receive services. They also point out on their website that there's not just one definition, right? So everybody, you can kind of pick different things to highlight about it, but they're not claiming that this is the only way to define it. And as you can see a little bit below, there's no universal definition or formulate for implementing harm reduction, thinking about that might be different for different populations. Any questions specifically about this? Feel free to chime in or ask in the chat. So now this is a second definition from SAMHSA's website. And they write, and you'll see there's kind of a lot more packed in here. Harm reduction is an approach that emphasizes engaging directly with people who use drugs to prevent overdose and infectious disease transmission, improve the physical, mental, and social well-being of those served, and offer low threshold options for accessing substance use disorder treatment and other health services. So there's a lot of kind of very specific goals packed in there. And they also write that it's an important part of the Biden-Harris administration's comprehensive approach to addressing substance use disorders through prevention, treatment, and recovery, where individuals who use substances set their own goals. So kind of highlighting, a few things in just the kind of orangish colored text here, that this is pretty clear about preventing overdose and infectious disease transmission as being important goals, but also thinking about improving physical, mental, and social well-being of people who receive services through a low threshold approach. So low threshold, for those, I imagine many have heard that, but is really thinking about, sometimes I like to visualize, an entryway. So if there's a door at street level, that's low threshold. You don't have to climb stairs to get in. That's not a barrier to anyone. Say somewhere where you have to climb a bunch of stairs to get in, that's kind of higher threshold, and you can think of those steps as each representing some of the barriers people encounter, not just for accessing treatment, but other services. And their broader definition here, you see that prevention, treatment, and recovery are sort of wrapped into this way of thinking about harm reduction, which may be different from organizations or other groups. And Donald writes in the chat here, for me, both these definitions resonate, one for the micro, one for the macro perspective. And this one can maybe feel like trying to put a lot in there. It might be, if you were explaining it to someone, that's a lot for that sort of social, meeting someone at a barbecue type definition, but, thinking about that as sort of a strategy roadmap, that's sort of more of the SAMHSA approach, at least there. And this third one I decided to include because for that project that I showed, we were working in Detroit, and one of the people I interviewed there, a community organizer, had talked to, I was asking a lot of people sort of how do they view harm reduction, and this was her response, which was really kind of made me think differently, and I was really struck by what she said. She said, I think about harm reduction from the point of view of the kids helping their parents and how we can reduce harm all around. if we're thinking about healing and supporting folks, harm reduction means creating safe spaces that don't make them feel isolated or shamed, a place where it's not on the kids, the parents can get help and not be judged. Because the minute you shame them, someone else has to pick up that ball you dropped when you could have showed compassion, and it's usually the kids or family members that still come around. So I thought that was pretty kind of striking in a way of, maybe engaging people who, don't think about harm reduction in that sense, or, the lived experience of family members, and particularly in this case, children. She told me that she grew up with a mother who had a substance use disorder and is now in recovery, as well as a stepfather who also had a substance use disorder and ended up dying for related reasons. So, seeing kind of both outcomes, but also this, experience of being the person who has to pick up the pieces, as she kind of says, or pick up that ball when someone feels like they can't get help through the healthcare system or other sources. Donald has a question. Do you feel harm reduction will interfere with awareness and endanger people's lives as well as themselves more than saving them? I think we're going to talk about kind of that, and sort of, when we get to some of the reservations people have. I don't think I don't see it as endangering people's lives. I think we can think about sort of, what the goals are in a specific context or setting. So you might be talking about harm reduction with young adults in an educational setting, whether that's high school or a college or university. And that might present differently than a syringe service program, that's approaching a different population. And then thinking about, to answer that question, also sort of what is the person identifying as their goal in that moment, kind of recognizing that those goals might be changing over time. I think also, maybe gets away from that saving them, other than kind of thinking about that from, an overdose context. So I think we're going to talk more. I hope that starts to answer that a little bit. But yeah, please feel free to continue that conversation in the chat and kind of share as things come up. So this is sort of just a simplified, that really even removes harm reduction from specifically talking about substance use or substance use disorder. So thinking about it as an approach that aims to reduce the negative consequences associated with risky behavior. So this could apply to many types of behaviors, right? So, for many people working in substance use and addiction treatment, you're thinking about it with respect to mostly drugs and alcohol and perhaps tobacco. But, if we think about other contexts, and this has been brought up a little bit in the chat, sometimes ways of helping people understand what harm reduction is, thinking about bike helmets as a way of reducing the risk of certainly living in New York and biking around city traffic. Sunscreen as a form of harm reduction. We all still want to go to the beach, and seatbelts in cars, condoms, these are all ways to reduce the potential harms of things we do that involve risks. So, these kind of, I like to present images and, think about presenting things that way. And this is sort of a partial list of principles, but I think boils down a lot of the concepts that different definitions get at. Thinking about it as an approach, not a single intervention. There can be a lot of harm reduction interventions listed separately, but as an approach, this idea of reducing the harms of risky behavior emphasizes respectful, non-judgmental interactions. So this is a population that, can feel very unwelcome or judged in different settings. And that one of the kind of core principles of harm reduction is kind of trying to remove that judgment and treating people with respect and dignity. Empowering people, that's something to, that people have agency, and this idea of empowering them to reduce harmful behavior by giving them the tools to do that and educating people, recognizes that, they can take steps to improve their lives and to reduce the harms of certain behaviors. And just reiterating something I mentioned earlier, that, it's really about supporting the participants' goals, which may change over time. I'm sure many of you have kind of responded to that in your work and kind of trying to elicit what those goals are. But, harm reduction as an approach is not trying to dictate this is what you should do, but really trying to identify and help motivate people to find ways to achieve their goals. Recognizes that abstinence from all substance use may or may not be a goal. And again, that's something that might change over time. Certainly in the current environment where using more than one substance is the norm, someone might be pursuing abstinence from one substance, but still using other substances. So kind of trying to recognize that there are different pathways and goals for people. And prioritizes holistic person-centered care. Holistic is one of those terms, you can think about it different ways, but, usually, and one of my hesitations about thinking about substance use disorder is it really puts the focus on the substance as opposed to some of the other behaviors and needs that people have. So person-centered care that's holistic really, expands the interventions to address other things, whether that's housing, legal challenges, education, employment hurdles. So just a couple things in the chat. Thinking about Vanessa Wright's methadone mile in Boston, where police sit at the corner of streets watching people who are living and using drugs on the sidewalks. There's certainly corollaries of that in different cities and even, some rural communities and suburban communities where, there are points where harm reduction is, more visible than it might be in other settings. Donald's question, even when we reduce someone's substance use, where we still leave the opportunity to use a dangerous drug behind them, still using drugs when they're reducing the number of times they're using. I might be missing the question here, but that, thinking about reducing use can also be a goal for people, that, thinking about treatment is sometimes more gradual or episodic as people kind of redefine their goals. I hope I'm capturing that well, but feel free to chime in or raise your hand if you would like to comment on anything. Just want to pause and give anyone a chance to comment on what's been shared. Or any thoughts?
Can we get clarification on the question? I think it might be a really good question. I'm curious as to if we're looking at, like, if the question is, are medications just as harmful? I guess I'm just confused on the question.
From Donald?
Yeah.
Yeah, I guess so that was Donald Burnett. So if you want to rephrase that or speak up, maybe we can answer it better. That might actually lead into the next. Donald, did you want to address that, or do you want to add anything in the chat? People are confusing medication with reducing drug usage. So I think this might, I'm going to table that for a little bit, and I think we will be talking about that kind of when we talk about, concerns people might have about harm reduction as an approach. So for those of you who are kind of working more in direct services, or, even if not, just putting out a question of, what are some examples of harm reduction related to substance use you've heard about or used? And feel free, again, if you feel comfortable just speaking, encourage anybody who wants to talk as well. Laura writes, reducing frequency, reducing amount of substances used, not using in unsafe environments. Eileen writes, utilizing MAT, medications for addiction treatment, sometimes referred to as medication-assisted treatment. Changing route of administration. Yeah, just 1 second. From injecting to smoking. Yeah, go ahead.
I'm just saying that people are confusing the medication portion of harm reduction to reducing their drug use. And if they're just going to reduce their drug use and not get into the medication aspect of using something different than the dangerous drug that they're using, they still left open to the opportunity of the dangerous drug.
Does anyone want to address the point that Donald's making? I have that kind of question about sort of concerns about harm reduction a little bit later in the workshop. So if you don't mind, if we kind of come back to that, I think that's a point that, people have that concern, if the medication is, a form of harm reduction, or if it should be considered a form of treatment, and kind of different perspectives on that we can share. For some people who are a little less familiar with harm reduction, want to kind of start with what some examples are here. So there's a few more in the chat. Safe needle exchange, using with others, naloxone, having a safety plan in place when using, safety planning for children, their children, fentanyl testing kits, fentanyl test strips, Narcan, so also known as naloxone, fentanyl test strips, syringes. Gary writes specifically, we'll talk a little bit more about xylazine, but shifting from injection to smoking as a way to reduce infections from xylazine. Considering the environment someone's in and triggers of settings. Maria talks about different treatments and working with someone to set their own treatment goals. So medication, psychedelic treatments, psychoeducation, psychotherapy, trauma-informed counseling, and EMDR, overdose prevention sites, not driving, very important one. We're going to talk about overdose prevention centers, using motivational interviewing to explore, right? Someone who says they would prefer outpatient versus an inpatient program if that was the first recommendation. So, thinking about harm reduction as engaging with that person and accepting their decision to try outpatient before, suggesting a residential or inpatient program. Suboxone, which we will talk about as well, so also known as buprenorphine. Again, just kind of showing some of the visuals here, first thinking about even more broadly, sometimes in the focus on drugs, we don't talk as much about alcohol or even nicotine, but, these are all forms of harm reduction that you could think about. So, just passing dry January for a lot of people, taking a temporary break from drinking is a form of harm reduction, or choosing low or no alcohol drinks. Designating a driver, big campaigns around that. That's a form of harm reduction, in the context of both alcohol and certainly drug use, or choosing nicotine gum or patches as a way to address smoking. So, these are all ways you could think about harm reduction. And then in the next slide, carrying naloxone and knowing how to use it, certainly the nasal spray there, also known as Narcan, is something that's getting more attention and training and education. Using new syringes and supplies, testing drugs with fentanyl test strips. So there's an example or an image of one of those on the right there. Is everybody familiar? I've had one person ask in other workshops for discussion about fentanyl test strips. Does anybody want an explanation about that? Feel free to, yes, okay, great. Okay, so a few people have never heard of them. So this little packet on the right, you open that up. I mean, to some degree, it's a little bit like a COVID test or a pregnancy test. There's a little strip inside it that you can use, particularly when the drug is in a liquid form to test. It'll show positive if there's fentanyl in that drug, or negative if there's not. Now, it's not going to tell you the amount of fentanyl So it's really just a binary that is fentanyl present or is it not? But, you know, this is something that's routinely kind of handed out, particularly through syringe programs, you know, and increasingly in other locations to allow people to discover whether or not there's a fentanyl, you know, especially as fentanyl has kind of showed up in crack, heroin, methamphetamines, and other substances. This is something that even states where they were previously not legal are starting to become legal in those areas. Donald Powell writes, you can also test utilizing the residue from the packaging. Yes, Duha writes, never heard of this. Are they free? Where can I get them? We'll talk a little bit more about these kinds of things, but you know, many syringe service programs, and I'm going to show another website that's helpful to kind of find resources in your state. And Penelope asks, would it be okay if I wanted to use any of these slides in sessions with people? Yeah, so you'll get all these slides. So kind of encourage you to kind of take what's useful to you and kind of share the information. Yeah, so Carolina writes, depending on the target audience, they can be useful talking about fentanyl test strips. In many cases, people are looking to use fentanyl, but they don't know the dosage. They can potentially overdose. Great. And how many of you have heard of the Never Use Alone hotline? Is that something that's come up? You can just use the little figure to raise a hand or answer in the chat. Great. Couple hands. So this is a hotline that people can call. I have the website up there as well. You know, some people, despite advice about never using alone, are going to be in context or maybe prefer the safety of, you know, not necessarily using around other people. So this is an option where someone can call about this hotline that's staffed, and, you know, someone will wait and make sure that they're okay after they've used, and if not, you know, call emergency services. So, you know, increasingly, this is a resource that's being talked about and kind of promoted to people, you know, if they're in that situation of not being able to use with other people. So thinking about that as a form of harm reduction so that there's, you know, someone who's going to respond in case that the person becomes non-responsive, then someone's on that phone who can call for help. Any other questions? Eileen has, oh, that might be responding to never using alone, but if you have a question and I'm not noticing you, feel free to just unmute and speak up.
One of the things we have to keep in mind around harm reduction is that this doesn't work the way that it can if we don't suspend our own prejudices, our own beliefs about certain things. So there are some harm reduction organizations. I'm on the board of On Point New York City, which operates the nation's only overdose prevention centers. One of the things that the staff do there is if they hear about a bad particular shipment or a bad brand, they inform the participants. Now, if your belief is, well, if you inform them, they're going to go want that, you're taking the decision away from them. You can't assume that because they know of a stronger potency drug, they're automatically going to use that. You then take away the person-centeredness. So I think that's really important in how we do this work, because if we don't, we run the risk of not being able to engage people. The other piece that I was talking about, I just want to go back to the definition stuff. I was really referring to the harm reduction definitions because I think social work school teaches you've got to address issues from the micro, which is the individual themselves, but also the macro. So we need to also be looking at how do we organize and advocate for better protections, better policies for people who use drugs. So for instance, I know, we're going to talk a little bit later about xylazine. I'm very, very concerned that there's no drug test for that. And so how are we protecting these individuals who use drugs? So that's my piece.
Great, thank you, Donald. I am going to be talking about On Point and Overdose Prevention Center, so I'm sure you'll be able to add some information there. I appreciate that. Carmen, you still have a hand there?
Yes, I was thinking as far as the idea don't use alone, I would like to know how when somebody calls in, that sort of for the person that's getting high, that takes away from the euphoric or the like doing it by myself thing and kind of even thinking who's listening, who's watching, who now has me using. And I don't know, I wonder about the effectiveness of that program, of if that really works. I wonder if there's a statistics or how many people call. I'm curious.
That's a great question. You know, I've not seen that. I mean, a lot of times just ideas for research, you know, I'm going to look into that and see if I can find anything, but I think it's probably self-selecting that people who are comfortable with the service are going to call and use it, and, you know, don't necessarily see it as interfering with their experience. So for example, you know, I've talked to and interviewed women who maybe for various reasons prefer to use not around other people, you know, and that might feel safer to them. So calling that hotline, you know, allows for that person on the other end of the line to, you know, and I don't know that someone listening, I mean, if you're choosing to call, you probably want the safety of knowing that if something happens, that someone is going to call 911 or 988 and a response will happen, as opposed to, you know, a risk of an overdose death. Terry?
Yeah, I just wanted to mention about Never Use Alone. You know, it's only been going for a few years, but there's been several reports and connections to reverse overdoses with that line, where they're hooked up to the local 911 so they can pass the information on to 911. So as far as success goes, you know, I look at success as if there's one life saved, that's, to me, that's success. I know in New England, it's been revamped, so it's part of Never Use Alone, but it's not called Never Use Alone again. They're rebranding it up here.
Okay.
But it's been yeah, all the SSPs endorse it and send folks their way. So
Yeah, great. And I think for anybody who's familiar with the 988 hotline and the National Suicide Prevention Lifeline, you know, it's kind of a similar concept of somewhere someone can call, you know, maybe when they're not feeling comfortable reaching out to someone within their own network. But, you know, and it's kind of a crowdsourced model. But Gary, if you are able to share any of that next week, you know, if there's links to reports or want to email, we can share that in the chat. And I think that's definitely, you know, as more research happens and you know, figure out what the effects are in terms of lives saved or people just kind of feeling comfortable connecting, and who's utilizing the service. And someone added a link in the chat. Thank you, Diana, that there are some stats on their page. So that's on the Never Use Alone website.
and I will invite our person up here in New England if you'd like to join the call next time.
Okay, great. So just kind of shifting to sort of specific services, you know, wanting to talk here about syringe service programs, which kind of can go by different names, but, you know, the acronym SSPs is kind of increasingly used to refer to these programs that are community-based organizations that provide sterile syringes and other supplies to people who use drugs. So this is sort of tend to be when people think about harm reduction and who's providing these services, that SSPs are sort of a core example of who's doing that work. So distributing the overdose reversal medication, naloxone, and doing training on that is, you know, one key part of that. Testing participants for HIV and hepatitis C and helping them get treatment, you know, maybe not done by all organizations, but often this goes hand in hand with distributing syringes and other supplies. Many offer food, clothing, showers, and mail services. Prevention Point in Philadelphia has probably the largest program to provide an address and mail services to people in Philadelphia who wouldn't be able to get, you know, identity documents and have a kind of fixed address other than through their service, which serves thousands of people now. Many have drop-in centers with respite options, peer support and counseling. again, depending on the level of resources, some portion or all of these services might be offered. Provide or connect participants to treatment for substance use disorders and medical care. So I'm going to be talking about a couple examples of places that have some more robust connections to care and treatment options. And some increasingly offer mobile services too. So, these might be people who are out, in a van, some on foot, the New Jersey Harm Reduction Coalition, I was able to go out with, on some of the work that they do, literally taking kind of a hand cart out into the street and in local parks there. So the real broad range of services, but this kind of captures some of the core things that they do.
Excuse me. One
Sure.
second, please, before you go on.
Yeah.
What did you say was the name of the program that offers the food, clothing, showers, and meal services?
So that
Called Prevention what?
So Prevention Point in Philadelphia, I just mentioned as an
Right.
example. I'm going to talk a little
Right,
bit more
thank
about
you.
them next week, but they have probably the largest mail program, so sort of
Okay.
providing postal services,
Thank you.
where recipients or participants can receive not just mail, but packages and other.
Mhm. Thank you.
Sure. So these are, people have asked about research and, it's pretty strong evidence showing that syringe service programs reduce HIV and hepatitis C infections, that they prevent overdose deaths by providing naloxone training and distribution, reduce syringe litter by offering safe disposal options. So many, in addition to distributing clean syringes, also take back syringes that have been used. So, that's a service that keeps them from being discarded on the street and in other public places. They connect participants to HIV, hepatitis C, and substance use disorder treatment, as well as other health services. Wound care is increasingly a focus, particularly with xylazine appearing that in the drug supply that has created kind of more needs for partnerships. So, some of the places that I visited have strong partnerships with whether it's medical schools in the community or other healthcare providers that kind of go out in conjunction with, some of the mobile providers to do basic healthcare and medical care, and then try to connect people who need more care to, whether it's hospitals or other healthcare providers. And pretty strong evidence that syringe service programs do not increase drug use or crime in the community. So there are a couple links there that, show from the CDC and the NIDA, the National Institute on Drugs Abuse, has kind of a broader listing of research around that. How many of you are kind of familiar with the syringe service programs near you or what exists in your state? And feel free to post in the chat. See a few hands up here. So this is a map I found. It's kind of acknowledged that it's not necessarily accurate or fully updated in terms, people have said, oh, I know our state has more than the number listed here. But the best estimates I've found, probably about 500 syringe service programs in the US. Many have limited hours or may only offer mobile services or be open, 2 afternoons a week. But you can kind of see the map there showing, states that have more of them. Again, the numbers are probably not reflective of kind of a real-time number, but this map comes from the Kaiser Family Foundation, and they draw data from the North American Syringe Exchange Network. So, both places you can go to sort of find out what's available in your state. And I'm going to share another resource as well. Penelope adds a link in the UK. Thanks for that. Hannah, did you have a question? Or was that from my last question?
It was from having a syringe
Okay,
service.
great. Just want to be sure I didn't miss anything there. So kind of moving on to overdose prevention centers. Thank you for sharing, Donald, that you're on the board of On Point here. So someone just asked Lisa's question here. I think I'm probably just well timed to that. Are we going to get any information on supervised injection sites? So, you know, these services have gone by kind of different names. So, you know, kind of landing, at least in the US and in New York, where 2 exist now, on Overdose Prevention Center as a name that's becoming more commonly used. You might have heard of them as safe injection facilities, supervised consumption sites, different acronyms there. But basically, they're hygienic facilities where people can use drugs. They offer education, equipment, and oversight of drug consumption. There's staff there trained to intervene if someone is experiencing an overdose. They provide or connect people with health and social services, including treatment. And they're about, as far as I can tell, you know, from the best statistics I could come up with, 150 in about 16 countries, give or take. If anyone has a different source to add to that, very much welcome that. And, you know, 2 opened in November 2021 in New York City at the Washington Heights Corner Project and New York Harm Reduction Educators in East Harlem. So all under the umbrella of On Point in New York City, which, you know, my husband was able to visit and photograph. So, you know, I got to see, I have not personally been there, but have watched a lot of the kind of videos of what's happening and followed that. This is from On Point's website, which is pretty regularly updated. They have had over 3,000 participants since they opened in November 2021. There were almost 66,000 utilizations of the Overdose Prevention Center. So that's not necessarily, that's different than the number of people, that first number. And they've intervened in more than 800 overdoses. So kind of important that they just call it an overdose intervention, which sometimes in the media reporting talks about, you know, that can get translated into prevented overdose deaths, which, you know, it's hard to know what would have happened with that overdose, but often intervene using oxygen as opposed to providing naloxone. But, you know, have staff there to kind of manage that experience. And sorry, I'm half watching the chat here. So, you know, this is a very kind of researched service, and, you know, you might be able to see a little bit in the notes here that the Center for Opioid Epidemiology and Policy at NYU Langone is leading an evaluation to assess the impact of On Point's OPCs on individual and neighborhood outcomes, such as non-fatal overdose and syringe litter. So there's going to be more research and continues to be more data coming out about that. But a few links that, actually I was jumping ahead. So the evidence that does exist, you know, mostly from kind of other countries, since they're pretty new in the US, is that, you know, overdose prevention centers or safe consumption facilities reduce overdose deaths and overdose related emergency calls in the neighborhood, reduce public drug injection and syringe litter, do not increase nearby drug-related crime, and, you know, serve participants who are not in contact with other health services. So, you know, increasing participants' use of health and social services, including treatment, is kind of an important role that these organizations can play, particularly as they develop, you know, ongoing relationships with participants. And that's just a link that has, you know, some more information about kind of research that's been done about OPCs. And these are a few more links that, again, will be in the slides when they're emailed to you after the second session. But this, I thought, you know, they've done a really great job of kind of working with the media, both when these sites open and the longer they've been open, you know, starting to put out information about, you know, what they've learned. So the first is an interview on a local radio show in New York City that I'd encourage you to listen to if you want to kind of learn more about how they're working in New York. And the second is a video created in partnership with On Point, just about what they've learned in the service they've offered. And then this is a report that, you know, people from the New York City Department of Health and other collaborators put out, just kind of I believe that, yeah, last year, in just what they had learned so far. So there is going to continue to be more information coming out, but this sort of ranges from, maybe more accessible media coverage to more research for those who are interested in that. Yeah, Penelope has a question. Can you say something about problems of locating such centers, where to put them, and how communities react? And I think that, what made it more feasible in New York City is both of these services opened in existing organizations that already had locations in the community. But there's no doubt that there's, that is something that has to be navigated with local communities. And I see Donald's hand is up to hopefully maybe address that.
So very quickly, a couple of things that happened is, so Washington Heights Corner Project and New York Harm Reduction Educators were two distinct long-serving organizations of syringe access programming, some other programming. So they had some credibility in the neighborhoods that they had been in for over a decade. So the merging of those two under On Point kind of created some synergy between the two locations. Some other stuff that happened is that staff from the two agencies, even before the merger, began to go out and clean up some of those spaces in the neighborhood that were kind of high volume drug use facilities. They began to do research to kind of pull in stakeholders. So they met with the NYPD, they met with the City Department of Health, they had meetings with the Commissioner of the Office of Addiction Support and Services. So there was a lot of synergy around this. And as the moderator was saying, you always get these statistics. The one thing that I'll also say is that among those overdose aversions, literally a fraction of them 911 had to be called. So that's even more amazing, because I think we have to realize the community that we're dealing with and their interaction with the police is very tenuous at best. And so these are all things that I think really, really went to the success of On Point. Now, having said that, I'll say that we literally have a governor who last year at the end of the session decided that she was not going to allow for funding of OPCs in New York State. Even while, she kind of ran on the importance of harm reduction services. So I say that to say that it is not impossible, but it is difficult. It is a shift in the way in which we do services. The last thing that I'll say is that it is a prevention center and not an injection site, because there's actually a room for people who smoke there too as well.
Thank you, Donald. So I think for the Governor Hochul, that you're referring to the opioid settlement funds, I believe. So, that's a source of funding. I mean, traditionally, both for syringe service programs and overdose prevention centers, where they're able to get funding and what funding streams will support these services, has shifted over time, but is always challenging. And I believe that what you're talking about is that decision not to use the New York's opioid settlement money for overdose prevention centers, correct?
In spite of the strong recommendations from the advisory board to do so, she went against those recommendations from this board that was set up to really manage where these monies should go. So that was a kind of turnaround. It was really disappointed. But what I will say is that the New York City Department of Health and Mental Hygiene has really stepped up.
Mm-hmm. Thank you, Donald. Gary?
Yeah, in advocating for these the overdose prevention sites, it's really important. We had the benefits up there, the benefits of a person who uses drugs, but we also have to look around at, at the communities where public injection of drugs impacts everyone in the community, and it impacts merchants because their bathrooms are being used. So that's a plus, like that. Those are the things you have to remember. What are we doing for the merchants in the community? What we're doing is like getting them out of their bathrooms, putting them in a sterile, safe site. And also it goes into like, tourism and stuff, like if you're going to come to Boston and see people overdose in the Boston Commons, it's not, you're not going to want to rush back there, so it benefits the community. And that's really, like some of the stuff that we have to highlight when we're advocating for this stuff, because there's always public hearings involved, and neighborhood groups getting involved, and it's beneficial to a lot of the folks in the community to have a place where people can go other than, in an alley where they're gonna, kids are gonna be walking home from school and seeing people shoot dope in their car and out in the streets. This is just so much, it gives so much more to the health of individuals and the community.
And I think, that again, that research, as more information comes out, I believe, so Sam Rivera, who's the executive director of On Point, and Kaylin C have also shared information in different kind of media interviews, but, that they had heard from the Parks Department that syringe litter, in the nearby area has really gone down. So, these things take time to kind of figure out what's working and then, what might have to be adjusted. But I think maybe contrasting with the experience in San Francisco, where I used to live, and what's happened in the Tenderloin neighborhood there, and kind of trying to figure out, the best approach. They had something that was, open. It was a more temporary facility, but, trying to figure out what to do about a lot of the street drug use and what the best alternative is while making it something that the community will support and can get funding. So thank you everyone who's sharing on that. Seymour kind of—
Can I say something about alcohol?
Sure, yes.
Because alcohol is still the #1 killer.
Mm-hmm.
And I don't know about other areas in the regions, but I'm quite sure they're affected by the nip containers.
Mm-hmm.
Where people are driving and they're drinking their nips and they're throwing them right out the windows,
Mm-hmm.
And that's become, I live on the Cape Cod, and that's a huge problem here. The state is, I don't know if they've done it yet or not, I forget. They are going to charge a deposit on those as one way to deter that behavior. But I'm also concerned where you had backing up where you have the idea of the concept of like making a designated time not to drink.
Mm-hmm.
My concern about that is withdrawal. So would that include somebody that's a heavy drinker? See, I'm not gonna drink on the 13th of this month, right?
Mm-hmm.
So is that going to include them just not drinking for that day and going into DTs, or do they need to go into treatment?
I think it's more, so this is something, and maybe remind me who's joining from the UK, that this concept of dry January is maybe not for a drinker who's, going to experience withdrawal, but someone who's maybe just wanting to, after the holiday season, rethink their relationship with alcohol or drinking, maybe it includes other substances. So, but that there is sort of, it becomes something that's the media is covering, that people are talking about, that maybe there's kind of a motivation because your friends are doing it. I tried it for the first time this year just to kind of see what would that be like. And it was very interesting to go to social events where, coming out of the holidays, still coming out of the pandemic, and say, no, I'm not going to have a glass of wine, that's offered after a screening or something. So I don't think the target is really people who, or it's saying to someone who would experience, physical harms due to stopping drinking suddenly, but more for someone who wants to just have a different relationship with alcohol for a period of time, not necessarily a month.
So that's say like there's somebody that's that is in recovery from addiction of heroin. And they say, oh, okay, so I can drink during the holidays and do this dry out January thing. So basically they've relapsed already.
Well, I think that's
on a substance, you know what I'm saying?
People would view that differently. So someone, again, it's thinking about not necessarily, if abstinence from all substances isn't their goal, and different ways of defining recovery. So for that person, maybe they have quit using heroin years ago, but still use, cannabis or other substances. I don't think that dry January is a concept that's like meant to motivate people to drink, or, it's really more about someone who might be creeping up beyond the recommended, weekly or daily servings of alcohol.
I see,
And
yeah.
kind of thinking about, okay, if I'm maybe having 4 or 5 drinks on a Saturday or weekend, or, in the UK at a football game, it is sort of a motivator to think about your relationship.
Oh, that's cool. Thank you.
I hope I addressed that, but anybody else, feel free to.
Thank you.
So back to kind of thinking about harm reduction, I think this is something that's, getting more support. For the first time, the American Rescue Plan included $30 million in grants for harm reduction services. There's since been kind of other funding streams that have started opening up to support harm reduction. And I had mentioned, this is just an example from the Texas Tribune that, Greg Abbott, the governor there, had, expressed support for decriminalizing fentanyl test strips, which, the Washington Post recently covered, the number of states that previously fentanyl test strips were not legal, but have kind of shifted their policy on that, partly in response to, the high number of overdose deaths and really wanting to make services available as much as possible. At the same time, this has already been brought up, that, support for some initiatives, does come up against, community or government opposition, or just not embracing it. So, I happened to kind of stumble on these 2 letters from different governors in California vetoing overdose prevention centers in California. So the first one is when Jerry Brown was governor in 2018, and then the second one is more recently Gavin Newsom in 2022. And you can kind of see, it's a little hard to read, but again, you'll get these slides, the different reasoning. Jerry Brown wrote, "I do not believe that enabling illegal drug use in government-sponsored injection centers with no corresponding requirement that the user undergo treatment will reduce drug addiction." And then by 2022, the language is a little different in this veto on the right, talking about a concern over the unlimited number of sites that this bill would authorize. Could induce a world of unintended consequences. So no longer using kind of language about enabling, but, expressing this worry about unintended consequences in cities like Los Angeles, San Francisco, and Oakland. Worsening drug consumption challenges in these areas is not a risk we can take. So there was a lot of media coverage, of both of these vetoes, and, in other places, certainly in Philadelphia, where overdose prevention centers have kind of been in litigation there. It's something that is kind of ongoing, kind of coming to terms with the level of support, or where communities kind of run up against limits. And that kind of gets reflected in media coverage, right? So this is as recently as, December on the left, a headline from The Economist, America's syringe exchanges might be killing drug users. On the right there, this is something, I come out of a background working in media, and also kind of looking at particularly how media has covered drug policy and addiction and treatment, and to a much lesser degree recovery. On the right, this story generated from some videos someone posted on social media, who had kind of gotten a young person to go to a park where a syringe service program was distributing supplies, and then filmed that person and what that person, who was a minor, was able to collect. And then that generated, other media coverage. And then, this headline on the bottom there. So, there's still a lot of disagreement in communities about kind of what to support and what to not. And I think in kind of thinking about it, just kind of leading into my, next question, it's important to kind of air these hesitations and concerns and kind of talk about, you know, what they are and how they can be addressed. So, you know, thinking about something that maybe isn't necessarily a personal belief, but, you know, if you want to add in the chat or speak up, what are some concerns or hesitations you've heard about harm reduction? Some of them have been mentioned, but feel free to just post in the chat. That people are only switching addictions. That one comes up, that it would increase crime in those areas. Yeah, these don't have to be things that, you know, are necessarily true, but just what would you hear, you know, or see in the media coverage or social media discussions that people have expressed about harm reduction approaches? That abstinence is the only way to address addiction, trading one substance for another, enabling, that still comes up. Thank you. Feel free to continuing adding here. But just, these are kind of common ones. And, you know, encourages or enables is a term that comes up a lot, you know, risky drug use, you know, a concern that it makes neighborhoods less safe by attracting people buying or selling drugs. Concern that it's spending taxpayer money on people who made bad choices. You know, this idea of choice and decisions comes up, you know, very much with respect to treatments for substance use and addictions. This has been mentioned in the chat, that medications, that offers medications that substitute one addiction for another, that harm reduction opposes abstinence and recovery, you know, that it only reduces some harms related to substance use disorders or just substance use. And then kind of more recently, I think, you know, this expression of that, you know, meeting people at where they're at, but then leaving them there can be a concern about harm reduction becoming an endpoint that is out there. And again, these are things that, you know, people have expressed, the media has expressed, or policymakers have expressed about, you know, hesitations about harm reduction as an approach. And I think it's important when thinking about how can you bridge, you know, harm reduction and treatment, which we're going to talk about more, you know, treatment kind of defined pretty broadly. You kind of have to wrestle with what people's concerns are and kind of putting them out there as one way to kind of start having those discussions. So a few things in the chat there. And at the same time, and, you know, we're going to talk more about treatment, but it's also important to think about what are the concerns or hesitations you've heard about treatment. So this is going to kind of lead into where we'll be going, you know, next week, that if we're trying to bridge harm reduction and treatment, you know, we'll be talking about what do we mean by treatment. So those of you who worked in treatment or had loved ones, certainly there are going to be some concerns that you've heard mentioned about treatment, or even things patients might have mentioned, or service users. Any thoughts on this? Okay, a few things popping up. Public funds and priorities, lack of empathy for people, a lot of zero tolerance mentality, people being kicked out of programs because they are non-compliant. You know, and it's important to remember that it's pretty fairly recently that treatment for substance use disorders was even covered by insurance, and people still face a lot of hurdles there. So, you know, largely this is something that existed outside the healthcare system and, you know, was very costly for many people to access when treatment was available. So this is just kind of a partial list of things that I imagine will resonate. You know, the idea that treatment doesn't work, you know, people kind of make that assumption sometimes because someone has cycled in and out of treatment. You know, it can be very difficult to evaluate success. You know, sometimes I think about it as, you know, if you have a pie graph and treatment being one slice of what helps people, that, you know, is it that treatment quote unquote did or didn't work, or did the person not get the other services and support they needed after receiving treatment? Another common concern that treatment can be too punitive, that kind of came up in the chat, that, you know, treatment programs, you know, historically could discharge people for minor infractions or a positive drug test, you know, so that's something that comes up often, you know, that can be a barrier to people wanting to seek treatment, that it's not available when needed. So, you know, mentioning this idea that there has been historically a two-tiered system based on income, you know, and insurance coverage, and certainly kind of involvement in the criminal legal system can separate sort of the pathways where someone might end up. Still reservations about offering medications for opioid use disorder, sometimes referred to as MAT, or medications for addiction treatment, and then many restrictions limiting access to these treatments. So we'll talk more about them next week, but medications like whether that's methadone or buprenorphine that are kind of very tightly regulated, even though some of those regulations are kind of have been relaxed recently. That treatment is too focused on abstinence as a universal goal, you know, that's not necessarily what some people are pursuing, and that treatment kind of needs to broaden the goals that people might define for themselves. And that treatment doesn't meet individual needs, especially for certain populations. You know, you could look at, you know, women being one example, people, LGBTQ plus people, you know, historically, you know, have found some treatment programs, and other populations that are not as welcoming. So, you know, these are just a partial list of things that come up sometimes when you try to talk about treatment, and people who have kind of hesitations or wariness about the outcomes of treatment. So these come from, I wanted to show some statistics. You know, this is from the National Survey on Drug Use and Health, which is a survey that's compiled every year. You know, the results are a little different, you know, trying to collect data during the pandemic and people's behaviors changed. But the latest one that came out is for data collected in 2021, and identified, you know, 16.5% of the population in the US age 12 or older as having a past year substance use disorder, which, you know, might seem high. And, you know, on the right, you can kind of see, and this has been brought up today, you know, as much as we focus on other substances, sometimes, you know, you see alcohol is by far, you know, the one that, you know, encompasses more people. Now, these are not necessarily exclusive, so someone might have a problem with alcohol as well as, you know, any of the other substances listed. But just curious, does that number seem high? Some no. Yeah, important to note that this is self-report data collection. So these are not people who've been diagnosed by a clinician, but uses survey questions to kind of assess that. So there are some, you know, criticisms of this survey that it's possibly over-representing, you know, substance use disorders in the population. But you know, it is also reflective of, you know, a time period during the pandemic where substance use definitely went up, along with kind of mental health challenges. Caroline says, I would say underreporting. And should also point out that this survey misses certain populations. So people who are incarcerated are left out of it, people who are unstably housed and in kind of some other institutional settings. So, you know, from that standpoint, it's likely that there is some underreporting. And this was kind of, if you follow kind of news more from the research, you know, pretty striking number that this was kind of identified as the need for substance use treatment in the past year. So if you look at the kind of point lower down, it's defined as having an illicit drug or alcohol use disorder in the past year, or receiving treatment at a specialty facility. But, you know, that population aged 18 to 25 is quite high there. And I think probably for many people working with that population or working in that field, that wouldn't be a surprise. But I think there's been a lot of attention on, you know, certainly that young adult population and the crossover with kind of both substance use and mental health challenges. And many of you have probably heard this statistic. You know, we talk about the treatment gap, and this is often cited as an average, you know, that only 10% of people who have a substance use disorder receive treatment. And that could be any type of treatment. So it might be outpatient, It might be a residential program, it might be an inpatient hospital program, but that, 10% is pretty consistently that average, with some impact certainly on treatment services in 2021. So the numbers are a bit lower here, possibly because of the pandemic. And I think kind of for the broader topic of bridging harm reduction and treatment, and then just kind of the challenges, there's challenges with treatment availability when people want it or need it. And, many of you who've probably worked to place people in treatment have, I'm sure, kind of run up against some of those challenges. But, I think this is a little bit underreported as a statistic that, almost 97% of people who, qualify, at least according to the survey, as having a substance use disorder who didn't receive treatment at a specialty facility. And again, that's not necessarily residential. The vast majority felt they didn't need treatment. So, thinking about bridging harm reduction as an approach with treatment services, this is a really high number and a barrier to kind of get over for many people, is that even if you kind of broaden out to the general population, that it's a hurdle to kind of help people recognize what services are available, and then make those services kind of appealing and attractive to people. But this is kind of consistent in most of the surveys that SAMHSA does annually. So just kind of checking in on the chat. Lisa says this. I'm not sure which statistics you were referring to there. Maybe the adolescent population. Any questions or comments about these slides or these statistics? And whether they kind of match up with what your experiences are or other surveys you've come across? Referring to not needing treatment. Yeah.
When I worked at Gosnold in 2021, I was at the detox as well as Emerson House. And they closed the men's house and merged the males with the females. So a lot of people were wanting to leave because they didn't feel they were receiving the services that they were there for, because the program did change. And also the detox, people were using that more like a revolving door.
Mm-hmm.
As far as coming into, they would say, well, I left treatment and, there was a discharge from treatment, or they left AMA and they went out and they used, and so they used coming back to the detox to use it as a detox.
Mm-hmm.
Or saying, yeah, and bragging about how much they overdosed, and having those conversations in the groups. We don't need treatment. But I can come here, I can overdose, they'll bring me to the hospital and then I'll come here. And I won't be sick because I'll get treatment. I'll be medicated.
Mm-hmm.
I saw that a lot.
Yeah, and so, you brought up detox too, and next week, one of the things we're going to talk about is sort of what do we mean when we talk about treatment? So there's not necessarily a kind of great treatment menu out there, when I've looked for graphics, and, often sometimes when we talk about treatment, it's talked about as a place. So whether you received it inpatient, outpatient, in a hospital, in another setting, as opposed to, what is the menu of specific services offered. So, we are going to be kind of looking at that and talking about, where treatment fits into kind of broader array of services that people might need. So just to finish up here, so then we'll be finishing up next week, same time on Monday, moving into a little bit more specific case studies next week, but, to discuss about how harm reduction providers are offering treatment services, including medications for opioid use disorder, mental health care, and other basic health care, often through partnerships in their communities. And then exploring how treatment providers are incorporating harm reduction practices into their work, such as not requiring abstinence from all substances in order to receive care. You know, lots of differences in how treatment providers approach this, but, you know, just hoping to kind of put some examples out there, and hopefully that, you know, you'll be able to share any that you've come across. Any other questions or final thoughts?
There's also the thing with the co-occurring disorders.
Mhm.
You know, that's a big thing now. And so I don't really see many statistics on that. Which
Mhm.
came first, the addiction or the mental health piece? And how with harm reduction, that's being treated.
Mhm. Yeah, great. I mean, I think that in some of the more robustly kind of funded harm reduction service providers, you know, particularly use of peer support specialists, you know, are kind of providing more of that, you know, navigator. They're called different things in different places, but talking about that and how, you know, mental health care and who's addressing that, you know, can happen in a lot of different ways in different venues. But thank you for bringing that up. There in that National Survey on Drug Use and Health, there is some data on kind of the overlap of people with substance use disorders and mental health. So I will try to add some of that. And Penelope adds in the chat, treating co-occurring disorders conditions, so important. Great. Well, if you failed it, share any questions if you have them before next week. Thanks for all joining today and, you know, sharing and participating. Have a great week and happy spring.